In this video, we are going to audit case 10.1, which is a lymphadenectomy with a prostatectomy. So our post-op, pre-op diagnosis are the same: history of adenocarcinoma of the prostate, procedure performed, bilateral pelvic lymphadenectomy with a radical retropubic prostatectomy. So our procedure states, please see the pre-operative note for indications of the procedure as well as full informed consent. The patient underwent a general anesthetic and was put in a modified front leg position. Anesthesia preparation included a central venous line, arterial line, and an epidural catheter. After this was achieved, a midline was deepened down through the skin and generous subcutaneous tissue to the midline. This was opened along the lines of the incision midline. The retropubic space was entered and developed. The pelvic lymphadenectomy was then performed. This was carried along the usual lines. The lateral extension was the external iliac vein. Tissues surrounding that vein were brought down and around the muscle wall to include the arburator group, preventing injury to the arburator artery, vein, and nerve. Proximally, we went to the circumflex iliac branches, including the node of Hoek, and then used clips across the trunks of the lymphatics. Distally or proximally on the patient, we proceeded to the bifurcation of the iliac vein, ending the dissection at that point. Again, the lymphatic trunks were clipped. Each package was delivered and sent to pathology for frozen section analysis. With the result of negative nodes, we proceeded with surgical removal of the prostate. This was performed in standard fashion. The Thompson retractor was used with modifications under padded retractors throughout the procedure. This allowed adequate exposure. The margin between the lateral and endopelvic fascia was opened in the anterior medial fashion to the puboprostatic ligaments, which were opened. The patient's size was fairly good. He had a large prostate, so the visualization in the apical area of the prostate was not great. We finger dissected along the superficial venous complex, reaching the apex of the prostate on each side. The McDougall clamp was placed through the fascia under the superficial venous complex but anterior to the urethra. Space was created there. A TIA 46 stapler was used to staple across the superficial venous complex. The urethra was exposed and open interiorly. Sutures at 10 and 2 o'clock were placed, 2-ochromic outside to in. The rest of the urethra was mobilized after the catheter was brought up and out of the wound and used for traction device after it was cut. The urethra was incised and sutures were placed at the 4 and 8 o'clock positions likewise. The apex of the prostate was mobilized using sharp and blunt dissection, carrying it down to the lateral pelvic facial levers. These were separated using sharp and blunt dissection off the lateral aspect of the prostate. Clips were used for small bleeding vessels encountered. The lateral pedicle was then mobilized between clamps and ligated with ochromics each side. Care was again taken to avoid the neurovascular bundle apparatus. The prostate was mobilized anteriorly and the denovelars fascia was opened over the seminal vesicles. Those were dissected posteriorly. The bladder neck was then incised down just behind the prostate. Because of the large medial lobe of the prostate, we had to open the bladder neck somewhat more than normal. We exposed the trigone but did not approach it. The prostate was dissected posteriorly off the bladder neck using sharp and blunt dissection. The seminal vesicles were then approached anteriorly as well as the ampulla of the vas. Each was cross-clamped and ligated. Final hemostasis was achieved at the point where the prostate was removed. We averted the urolithium and closed the bladder neck slightly. We then brought sutures concomitantly from inside to out at 2, 10, 4, and 8 o'clock. An 18 silicone catheter was placed in the bladder and the sutures were tied down. Hemovac drains were placed and the wound was closed with double-stranded running nylon Skin clips were placed and the drains were secured. He tolerated the procedure well. So, one or more of the following codes are reported incorrectly for this case. Indicate the correct code or codes. So our codes, it has CPT for the prostatectomy 55840, pelvic lymphadenectomy 38870 with a modifier 50 for bilateral, and then our diagnosis is a prostate neoplasm C61. So let's start in our ICD-10-CM book. We're going to look up our diagnosis code. So open up your CM diagnosis to the C61, which reads malignant neoplasm of prostate. That is correct. Tells us use additional code to identify. We don't know if our patient has hormone sensitivity or rising PHA. Neither is documented, so we cannot assign an additional code. Neither was documented. So C61 is correct. Now go to your CPT book and let's look up our procedures. So the first procedure was 55840. Says prostatectomy retropubic radical with or without nerve sparing. And if we look, with lymph node biopsy included limited pelvic lymphadenectomy, or right here we have with bilateral pelvic lymphadenectomy including external iliac, hypogastric, and our purturator nodes. So we do not code the lymphadenectomy separately. We want to code the prostatectomy radical retropubic with or without nerve sparing with bilateral pelvic lymphadenectomy, including external iliac, hypogastric, and arburator nodes right here. So if we look at the other code that was assigned, the 38870, that is a typo. As you can see in the answer key, it should be 38770, not 38870. So this tells me a pelvic lymphadenectomy, including external iliac, hypogastric, and arburator. Separate procedure, but we can't code as a separate procedure because it is part of our 558. Four or five. So that is the code that we will assign. So now let's go to find a code and look there. Okay, once you go to find a code, we can just go right to the tabular. So if you go up to my codes, and then we're going to pick let's do the ICD-10 first. And again, you can do codes, guidelines, index. We're just going to type our code, which was C61. Hit enter. We can just verify there. Same thing that we saw in our actual ICD-10-CM manual. Now if we go back to codes for CPT, index, again, we can just type our code 55845, hit enter. and it brings up just the code. Again, we cannot look through everything without buying an additional subscription. The other thing, remember, is we could go back to our report if we wanted, copy and paste again, Control C to copy, and then go back to find a code. And if we go up to the tools, to the scrubbing, we can go to the code and note and paste, Control V, and then scroll down and hit the search or scan. You can always see what codes the code and note, which is the computer assisted coding, brings up. But again, remember, it is just finding keywords and linking codes to the keyword. Nothing with the coding guidelines or following coding procedures. So let's see, it's taking just a minute to find this. Let's see what codes it comes up with. So we can see it did not assign our adenocarcinoma of the prostate at all, not even a choice. And then if we go to the CPT, it does not have our prostatectomy either. So good to know that it's always important to audit what a computer-assisted coding program does, because they just are geared to pick out keywords.